G'day. Welcome to Emergency Medicine Topics in One Coffee. I'm Giles, an emergency physician, and today we're going to talk about cerebral CTs, but not in trauma, so all the other things. So I thought we might look at strokes, both ischemic and hemorrhagic, venous sinus thrombosis, subarachnoid hemorrhage. We should look at space-occupying lesions, both metastases and primary tumours, a couple of infections, and maybe some calcifications that you should look out for. I think that would cover most of the things that we are asked to look at for in CTs in the emergency department outside of trauma. Okay, so let's look at strokes first. So we look at ischemic strokes. Ischemic strokes are caused by thrombosis or embolus, normally or most commonly in the anterior circulation, and the branches the anterior, middle and posterior cerebral arteries. Now, the distribution broadly of those you can see just up here now. So what happens when they're obstructed? Well, if you rush them through, you've got a stroke protocol, goes down, you get a cerebral CT done immediately, they've presented really early, you might only get the hyperacute changes. Now, the hyperacute changes are quite subtle. You may see a hyperdensed artery, like you can see here. You may see something called the insular ribbon sign, where the insula has edema. Now, this is actually it here. Often there's very little else to see initially. Over the next couple of hours, the patient will develop edema in that area, which is why it gets darker on a CT and why it starts to swell. And you can see it more demarked in the next few hours. Now, this edema, which we can see here starting out, gets worse and worse. In fact, maximizes at about 3 to 7 days. Now, as that maximum then goes past that, it then starts to resolve and the body starts to resorb some of that cerebral tissue, and you head to an area where you actually involute that area and the CSF comes in and fills that gap, an old CVA like this. Okay, so that's what you see on a CT with an acute ischemic stroke. Now, it's a lot easier with a stroke to see it on a CT if it's a hemorrhagic stroke. Now, these tend to happen inside the thalamus and sort of the subcortical white matter, and you can see them often in the cerebellum, often in patients who have a background of hypertension. So this is a sort of appearance that we see here. Now, as that resolves, you can often see around that a little bit of edema around that infarct, that hemorrhagic infarct. Okay, let's move away from ischemic and hemorrhagic infarcts, and let's look at venous sinus thrombosis. Now, clinically, you've got to be quite suspicious about these. They might present somewhat atypically, some fleeting sort of neurology and a headache. But you're looking for it on the CT, you can see here that there's a hyperdense superior sagittal sinus, isn't there? And then here, characteristically peripherally, you can see an area that's infarcted. This is not a classic sort of area you'd expect from a thrombotic arterial infarction. And in this particular patient, there's been hemorrhagic transformation. This next case, you can see here, they've given intravenous contrast, and that's outlined the thrombus that's in the superior sagittal sinus. And that filling defect looks like what's called an empty delta sign. You might have heard of that, and that's the appearance of it here. Okay, so what about subarachnoid hemorrhages? Patient comes in, classically headache, and the worst headache in the world, and they get a CT. Now, you should be looking for the hyperdense appearance of blood in the CSF spaces. So the CSF spaces to look for, well, the Sylvian fissure, and you should compare one side of the Sylvian fissure to the other side. Also look for the other cisterns, the basal cisterns, because in there, normally they're CSF filled. But if they have blood in the subarachnoid space, of course, that will be inside the CSF cisterns also sometimes. Okay. So let's move along into space-occupying lesions. They may be primary or secondary. If you look at secondary, look at metastases. Often when you look at the CT initially, you don't see the met, you see the effects of it. You see surrounding compression you see edema, and you may see edema in one area for a single met or multiple areas. It's when you give intravenous contrast here, and you can see that they sort of light up the appearance of metastases. What about primary tumours? Well, in adults, most commonly they're gliomas, and the gliomas go all the way to glioblastoma multiformes. As you imagine from glioblastoma multiformes, they are multiformed, so that they have a variable appearance. And they can appear like this. Here's another glioblastoma multiformes, the dreadful things. This one is a patient which I thought had a glioblastoma multiformes, and this turned up to be a cerebral abscess. So you've got to be careful about sort of jumping in. One other tumour we should probably be aware of the appearance. This is the appearance of cerebral lymphoma. Okay, so we mentioned about cerebral abscesses. There are a whole heap of infections that you can find inside the brain, and they have variable appearances. This is like a chidiomycosis, looks like that. Cerebral abscesses, amoebic abscesses. So they have a whole group of sort of infections, and that's really why we pay radiologists, so that they can interpret some of these things before we get tissue diagnosis. There's another infection here that's worth remembering. This is actually the appearance of HSV, herpes simplex infection. And you can see where it's got that predilection for the temporal lobes. Okay. The last thing I wanted to bring up was the appearances of normal calcification that occurs. Here's calcification of the basal ganglia, often seen bilaterally. Calcification of the choroid plexus. Remember, calcification of the pineal gland, that can mislead you, and calcification of the dura. And occasionally you'll see calcified meningiomas, which you may misinterpret. Okay, so we've briefly looked at strokes, both ischemic and hemorrhagic. We've looked at venous sinus thrombosis. We've looked at space-occupying lesions, that is metastases and primary ones. We've briefly gone through a few infections, and we've looked at subarachnoid hemorrhages, forgot that one, and we've also looked at some normal calcifications. Look, I reckon that'll do for cerebral CTs, not in trauma, in one coffee. Thanks for listening. I'll catch you next time. Cheers.